Looking forward, the most promising and ethically sound vision for AI in healthcare positions these systems as health companions rather than doctor replacements, tools that support, educate, and guide patients while preserving essential roles for human medical professionals. Realizing this vision requires deliberate choices about development, regulation, and implementation. The companion model envisions AI handling aspects of health support that are time-consuming but don't require human judgment or physical presence. Medication reminders, appointment scheduling, symptom tracking, health education, answering routine questions about conditions and treatments. These are valuable services that AI can provide efficiently and accessibly. This frees healthcare providers to focus on aspects of care requiring human expertise: physical examination, diagnostic reasoning, complex treatment decisions, empathetic support during difficult diagnoses, and the longitudinal relationships that characterize excellent primary care. Low-risk triage is an appropriate AI role when designed with adequate safety margins. AI could help people determine whether their situation requires emergency care, urgent attention within 24 hours, routine appointment in the coming week, or self-care with monitoring. This triage function, if executed reliably with conservative thresholds that err toward recommending evaluation, could improve healthcare efficiency and reduce both unnecessary emergency visits and dangerous delays in seeking appropriate care. Education and reminders represent high-value, low-risk AI applications. People with chronic conditions need ongoing education about disease management, symptom monitoring, medication adherence, and lifestyle modifications. Providing this education individually through human healthcare workers is resource-intensive and often incomplete. AI can deliver personalized, comprehensive education that adapts to individual comprehension levels and reinforces key messages over time. Medication reminders and appointment notifications are already common digital health features that AI could enhance with more intelligent, context-aware prompting. Humans must retain responsibility for examination, diagnosis, and high-stakes decisions. Physical examination provides information that cannot be obtained through patient self-report. The experienced clinician observing a patient, noting skin tone, breathing pattern, movement quality, and hundreds of subtle clinical signs, gathers data that no description to an AI could replicate. Diagnostic reasoning at its highest level involves pattern recognition, probabilistic thinking, and integration of diverse information streams in ways that current AI cannot match, especially for complex or unusual presentations. Empathy and human connection are irreplaceable elements of healthcare. Receiving difficult diagnoses, navigating treatment decisions with uncertain outcomes, coping with chronic illness or terminal prognosis, these experiences require genuine human empathy and presence. AI can simulate supportive language, but it cannot provide authentic human connection that acknowledges shared mortality, vulnerability, and the profound meaning of health struggles. The therapeutic relationship between patient and provider has healing value beyond information exchange, and this cannot be algorithmic. Clinical judgment in ambiguous situations requires wisdom that AI lacks. Medicine constantly involves decisions where evidence is incomplete, multiple factors compete, and the right answer depends on patient values and circumstances as much as medical facts. Should this elderly patient undergo aggressive treatment with significant side effects or focus on quality of remaining life? How do we balance treatment benefits against risks for this pregnant patient? These judgment calls require nuanced understanding of human values, not just data processing. Success of the companion model depends on multiple conditions being met. Regulation establishing safety and efficacy standards is essential. AI health tools should be evaluated similarly to medical devices, with requirements to demonstrate that they're safe, accurate for intended uses, and actually improve health outcomes rather than just providing convenient features. Pre-market testing, post-market surveillance, and adverse event reporting should apply to AI systems that significantly influence health decisions. Evidence requirements should be substantial before AI health tools gain widespread adoption. We need rigorous studies demonstrating that AI companions improve rather than worsen health outcomes, reduce rather than exacerbate disparities, and enhance rather than undermine the healthcare system's effectiveness. This evidence should come from independent researchers without financial conflicts of interest, not just from companies developing AI products. Clear role boundaries prevent scope creep, where AI gradually takes on more medical responsibility than appropriate. AI should be designed and marketed specifically for companion functions: education, reminders, low-risk triage, symptom documentation. Marketing suggesting AI can replace doctors or provide medical advice should be prohibited. Users need clear understanding that AI supplements professional care but cannot substitute for it. Continuous evaluation and adaptation are necessary because both AI capabilities and healthcare contexts evolve. Systems that worked safely at launch might develop problems through model drift, changing user behavior, or healthcare system changes. Ongoing monitoring for adverse outcomes, regular accuracy audits, and mechanisms to rapidly address identified problems ensure AI health companions remain safe and effective over time. Community engagement in shaping AI deployment ensures tools actually meet patient needs and respect diverse cultural contexts. Healthcare communities should have input into what AI tools are adopted, how they're implemented, what safeguards are necessary, and what alternatives exist for people who prefer not to use AI. Technology shouldn't be imposed on communities, but should emerge from dialogue about how to best support health in specific contexts. Equity considerations must be central to companion AI development. These tools should be designed to reduce rather than worsen health disparities. This requires ensuring accessibility across socioeconomic levels, digital literacy ranges, languages, and cultural contexts. It requires training data representing diverse populations so AI works equally well for everyone. And it requires monitoring actual outcomes across populations to verify that AI benefits reach those most in need of healthcare support. Integration with human care systems prevents AI companions from fragmenting care. AI should connect to and inform the healthcare system, not operate in parallel to it. When AI identifies concerning patterns in someone's symptoms or adherence, this information should reach their healthcare providers. When patients use AI for health education, their doctors should know what information patients received. Seamless integration ensures AI enhances rather than disrupts continuity of care. Financial models that don't disadvantage people without AI access are crucial. If healthcare systems reduce human service availability because AI covers certain functions, people unable or unwilling to use AI face reduced care access. The companion model works only if AI adds capacity without reducing human care availability. This might require policies mandating maintenance of human service levels regardless of AI availability. The alternative to thoughtful companion model development is chaotic, commercially driven AI proliferation that happens regardless of safety concerns, equity impacts, or healthcare system effects. AI health tools will continue developing and spreading. The question is whether this occurs through deliberate, evidence-based, equitably focused processes or through unregulated market forces that prioritize adoption speed and profitability over patient well-being and health equity. Professional medical organizations, patient advocacy groups, health systems, policymakers, and AI developers need to collaborate on defining appropriate AI roles in healthcare and establishing systems ensuring AI serves rather than undermines health. This collaborative governance model brings multiple perspectives to bear on complex questions about AI deployment and creates accountability mechanisms that pure market approaches lack. The vision of AI as health companion rather than doctor replacement is both optimistic and realistic. Optimistic because AI could genuinely enhance healthcare access, education, and efficiency if developed thoughtfully. Realistic because it acknowledges AI's genuine limitations and the irreplaceable value of human medical professionals. Achieving this vision requires active effort, adequate regulation, continuous evaluation, and commitment to equity. The path is challenging, but the potential benefits for population health make the effort worthwhile. The key is maintaining focus on using AI to support human flourishing rather than allowing technology to reshape healthcare in ways that serve commercial interests or convenience at the expense of patient well-being and health equity.